Good evening, everyone. Welcome back to my AVFenses and the European Fertility Society. We are back once again with more topics, and today we will discuss recurrent pregnancy loss and immunological factors. And we have our special guest with us already. As you can see, Dr. Abraham Zavala is with us. I'm really happy to have you back. This is the first event this year with you. So thank you so
Yes,
much for joining us. And how are you? Are you ready to discuss this topic for sure today?
yes. First of all, thank you, Caroline, for having me back on. It's always a pleasure to be here with the My IVF Answers community. And I think that this is a very interesting topic, and the focus that we're giving it with the immune factors, I think it's going to be very beneficial for everyone as a whole. But I think it's also a bit more complicated than just speaking about RPL in general. So I think we're going to have a good conversation tonight.
Definitely. And as always, just please remember we will start with the presentation so Dr. Zavala can explain all aspects that are important to discuss when it comes to recurrent pregnancy loss and immune factors. But of course, right after that, there will be time for your questions. You did send us some questions in the upfront, so we already have them. But of course, remember this is live event, so we are definitely here for you. So don't hesitate and put your questions in the chat, and Dr. Zavala will be happy to answer them for you. And just to let everyone know, Dr. Abraham Zavala, he's the fertility specialist at Clínica Tambre in Alicante. So we are definitely happy to have you here. And let me just go to the presentation. We can start, I believe. Just let me know if you can see it.
Yes, I can.
Brilliant. Thank you so much. Let's go ahead with the presentation.
Thank you. Okay. Well, just before we begin, I just wanted to remind everyone that Clínica Tambre and myself, we will be at the Future Fertility Show in Dublin from March 21st to the 22nd. Okay, just to keep that in mind, and whoever's going will be able to see each other there. So let's just remember that. So today we're going to speak about recurrent pregnancy loss, or what we call RPL. But as I said, we're going to focus on some of the immune factors that may be underlying causes into this condition. I think that it's important that we go over everything that we will speak about, because first we're going to talk about the definition of RPL, what it actually means, and what constitutes a what we call a pregnancy loss. We're going to look at the potential causes with a focus on the immune factors. We're going to talk about how we go about diagnosing this condition and what sort of tests your doctors might require or may need to further evaluate this condition. And we're also going to talk about the management options in terms of a general overview of the type of treatments that may be proposed when RPL is diagnosed. We're also going to talk about two real patient cases that we've decided to include today. I think that those are going to be very interesting for everyone. And then we're going to go with some key takeaways from today's presentation. So I'd like to start out with what the definition of RPL is. As I said, RPL stands for recurrent pregnancy loss. It is sometimes used interchangeably with recurrent miscarriage, but there are some slight differences. So a pregnancy loss is going to be defined as any spontaneous end of pregnancy before week 20. This includes any type of pregnancy loss. While miscarriage is also going to be a pregnancy loss before week 20, but it's going to include only pregnancies that have been confirmed by an ultrasound scan. Now, the way that we can say that we are facing a case of RPL is when we have more than 2 pregnancy losses. 2, 3, 4, 5. It doesn't make any difference in terms of the definition, but anywhere from 2 pregnancy losses is now considered RPL. And when I say now considered, I do want to emphasize this, because we used to need a total of 3 pregnancy losses, whether they were sequential or whether they had full-term pregnancies in between. That used to be the definition. But now, in order to begin the workup and hopefully treatment earlier, we begin by defining the condition with 2 or more pregnancies. So it's important that we understand that RPL is not caused by a single reason or a single cause. And in fact, we do have risk factors that are associated to RPL, but up to 50% of women might not have any of these risk factors. So it's not having a risk factor doesn't necessarily mean that a person wouldn't go through RPL. And it also means that a person that has RPL but doesn't have any of the risk factors, it doesn't mean that they're not struggling with the condition. And while the definition states that any pregnancy below week 20 can be defined as a pregnancy loss, it's important to understand that most miscarriages or most pregnancy losses will happen before week 12. And in fact, when I say most, I mean up to 99% of pregnancy losses happen before the first trimester, right? And there are 2 large categories that are associated with causing RPL. The first cause is related to the embryo, and the second cause, which is what you'll see on the right of your screen, can be large or grouped together as the environment that that embryo is being placed in. So embryo and embryo's environment. So speaking about the embryo itself, it's important to understand that we all, or most of us, I've personally never tested myself, but most of us are going to have 46 chromosomes, right? And that's what's going to define a normal karyotype, meaning a normal arrangement of a person's chromosomes. And we expect an embryo to also have 46 chromosomes. Now, sometimes this doesn't happen. And this can sometimes happen because maybe one of the parents, either the egg cell or the sperm cell, may not start out with a normal karyotype. So if the female or the male don't have 46 chromosomes, then there's a chance that the sperm cell or the egg cell are not going to have, well, 23 chromosomes, because eggs and sperm cells have each 23 chromosomes, so that once fertilization occurs, this should add up to 46 chromosomes. So that's one of the reasons why the embryo may not have 46 chromosomes. But in reality, the main reason why embryos sometimes end up not having 46 chromosomes is because when the genetic material is being rearranged, it can be rearranged in a way that doesn't end up in 46 chromosomes. There are many factors that may go into this, but most of the time we really have no control over how these genetic materials mix with each other. But we do know that both egg quality and sperm quality have an impact on how the embryo becomes a what we call a euploid embryo, an embryo with 46 chromosomes. But the most important factor that we can identify right now is egg quality. Now, since we can't measure egg quality, there's not a specific test like we would have for egg quantity. So we don't have an AMH blood test or a antral follicular count imaging test to be able to determine quality. The only factor that we can relate it to is age. So this is the graph that we see here. And in this graph, we can see the percentage or the likelihood for a person at any age to have an aneuploid embryo or well, in this case, a proportion of miscarriage. And as you can tell, it increases as age increases. Now, egg quality and the embryo's genetics is not the only factor that may cause or may be implied in RPL. It is the most common factor, but it doesn't necessarily have to be the only one. In fact, some of the correlations that we've seen is that the more miscarriages that happen, the less likely that a genetic factor may be involved. Not always, but it seems like there's that sort of trend. Now, when we talk about the other types of causes for RPL, the environment that the embryo goes into is an important cause. So anything from anatomical causes, so maybe a uterus with a malformation, with a septum, with a smaller cavity, what we call a T-shaped uterus or dysmorphic uterus, or maybe polyps or fibroids that may be inside of the cavity. Also, an inflammatory process, such as a chronic infection that has maybe gone unnoticed, can also be involved in RPL. And these sort of infections can be caused by many different pathogens. So it's important to keep this in mind. Now, I don't want to dwell too much in these sort of causes of RPL because I do want to focus on the immune aspect of it. But if you have any questions about it, you can always ask them, and we can go a little bit more deeper into this particular topic. Now, the reason why immune factors are even a thing related to the embryos, because we have to remember that implantation is an immune regulated process. I mean, your body is basically designed to keep anything that's not you out of you. That's the one of the main objectives of your immune system, amongst other things. And an embryo is always going to be at least 50% not you, right? In cases of egg donation or embryo adoption, those percentages are going to change. But overall, we know that it's at least going to be 50% of a foreign genetic material to your body. Now, the embryo is going to need to attach to your endometrium. Once it attaches, it's going to try to seek blood vessels so that it can start having that communication with the mother's organism and start thriving through that nutrition. And this is where some of the immune factors may come into play. The reason why I'm saying may is that, and I do have to have this disclaimer, while some immune conditions have been there's a consensus that they can affect miscarriage rates. Not all of them have enough evidence to be considered a sort of dogma in that sense. So, for example, there are these conditions called thrombophilias. And what a thrombophilia is, thrombo coming from clot, conditions that may predispose that person to forming blood clots at a higher rate than the general population, perhaps. And some of these are going to be inherited, meaning that they're going to be genetic, while some are going to be acquired. Now, it's clear that genetic thrombophilias, you're born with, your immune system has very little to do with that. But acquired thrombophilias are going to be caused by certain antibodies. So those are going to be mediated by your immune system. Now, not all conditions are related to forming clots. Not all of these genes are related to forming clot or to clot formation. Um, but certain genes like the lead in factor 5 can be related to forming clots. And some of the acquired conditions like APS or antiphospholipid syndrome has been implied in both miscarriages, in infertility, and in problems during pregnancy. So it's important to remember that not all inherited thrombophilias are going to actually be related to RPL. Some are. And antiphospholipid syndrome, which is an acquired thrombophilia, is related to RPL. There's also part of the immune system which is going to interact directly with the embryo's implantation process. And that is a type of white cell called the natural killer cell. Now, there are different types of natural killer cells. There are angiogenic NK cells. There are cytotoxic NK cells. There are NK cells that flow through your circulatory system. And then there's NK cells that are going to be specifically inhabiting your lining. And these NK cells are going to mediate the crosstalk with the embryo and the lining. So they're going to help the embryo undergo the implantation process. And it has to be just right. Can't be too much, can't be too little. And it has to be just right. And the way that this NK cell is going to interact with the embryo is through something called a KIR receptor. So the NK cell is going to have a KIR receptor, while the embryo is going to have an HLA phenotype, okay? And we know that certain KIR combinations, because there are different types of KIRs, just as there are different types of HLA, some KIR HLA combinations may not be ideal for implantation. They may be associated. We don't like to use the word incompatibility. We don't yet fully understand these interactions, but we do know that certain combinations are not ideal for implantation or for pregnancy. Okay, and we will discuss this a more in depth later on during one of our patient cases. Okay, so thyroid function is something that has also been studied extensively into its relationship to RPL. We know that ideally we want to have a normal thyroid function. Now, defining what that normal thyroid function is can be complex, okay? We know that in the general population, having a certain TSH value is going to be considered normal. For women that are pregnant and for women that are trying to get pregnant, we'll sometimes have different values of what a normal TSH means. Whether or not antibodies have anything to do with this, or whether or not we need to treat anti-thyroid antibodies has not yet been established. But keeping a good thyroid function by keeping adequate TSH levels is one of the things that we would look after to avoid miscarriages and certainly RPL. PCOS, obesity, and vitamin D deficiency can also in some way be related to RPL. So they are important conditions that we should treat. In terms of obesity, it's important that we understand that with a higher BMI, there could be an increased risk of miscarriage. But I think that the emphasis that we should have with a higher BMI is to go over the steps that may help the condition, because we know that it's not something that we can often easily treat or easily revert or transform, and we need to be aware of that it's not always going to be, we're not always going to be able to get to an ideal a BMI. So it's important that we know what ways we can do to try and help with that condition. So in order for us to even think about ways in which we can treat these conditions, we have to first be able to find out that these conditions are present. So some of the ways in which we can find out, whether we have a normal amount of chromosomes, or whether they're arranged the correct way, that would be something that's something called a karyotype test, and it's a blood test that we can do. Both the female and male partner can each do their karyotypes. We can also do a thrombophilia panel to establish what sort of mutations there are that could increase the clot rate. We can do a blood test to establish both the mother's KIR and HLA and the father's HLA and see how those markers interact. Through a blood test, we can also test for vitamin D levels. Vitamin D is something that, our clinics in Spain and Alicante specifically. So patients always say, "Oh, vitamin D levels here must be so high." Well, no, because it's the amount of sunlight and the time of the day in which you have to be exposed to that sunlight is quite specific. So yes, in Spain, we also have patients with lower levels of vitamin D. So supplementation in those cases is always warranted. The sperm analysis, we can test for whether most sperm cells are going to have a normal amount of chromosomes, so 23 chromosomes. We can also do a DNA fragmentation test to see if the rates of fragmentation are okay or whether they're too high. Through a PGTA analysis, we can establish whether the embryo has the correct amount of chromosomes or not. A hysteroscopy or 3D scan can sometimes rule out some conditions that may be affecting the uterine cavity, like fibroids, polyps, any malformations, dysmorphic uterus, T-shaped uterus. This is something that we can find out through both hysteroscopy and 3D ultrasound scan. And lastly, the endometrial biopsy can give us more information about that environment that embryo is being placed into. It can also give us information about the number and type of NK cells present. It can also give us information about the microbiome at the time, whether there are any signs of chronic endometritis, any inflammatory processes. So these are all conditions that should not be used in a general sense, but tailored to specific conditions and specific patients. So the ESHRE, which is the European Society for Human Reproduction and Embryology, has established a guideline on how to approach RPL. As I said, when a woman suffers a miscarriage, typically this doesn't mean that further studies or further treatment is warranted. This is a very delicate situation, of course, because we know the impact that even a single miscarriage can have, but it's also important to remember how common miscarriages are, and how additional treatment or additional testing is not always the right way to go, right? But if there's more than one miscarriage, in that case, some tests are set in place to be used in these sorts of population or patient populations. So what we talked about, the APS syndrome or antiphospholipid syndrome, that's something that should be tested for, and if proven to be positive, blood thinners are usually required. Blood thinners such as low dose aspirin, uh, uh, um, low molecular weight heparin. These are the types of treatments that we would use if we were facing an antiphospholipid syndrome. For overt hypothyroidism, levothyroxine is the medication that we would use. Based on weight, we would calculate the dose that we would need. For uterine abnormalities, not every abnormality is going to require any treatment or surgical treatment, but there are some that may benefit from actually being treated. And of course, psychological support should always be offered. We know that it is a difficult condition for not just the woman but also the man. For the couple as a whole, it can be a very challenging time, and it's important to remember that psychological counseling can always help us in these types of situations. So we know that RPL is both prevalent and distressing. It can affect the quality of life, not just of the female partner, but of the couple as a whole. The psychological burden that RPL brings, especially with couples or with women that may feel like there's just no way out of it, and that can be disheartening and distressing. So, as I said, psychological counseling should be offered in these cases. Unfortunately, outcomes haven't improved much in the 90s with or since the 90s. So it is important to try to approach these cases very proactively when established. So it's also important to make way with research into defining, to have better definitions and thus better approaches to RPL, because unfortunately, even with research, it's difficult to get a uniform patient sample, because there are different definitions for RPL, pregnancy loss, whether biochemical pregnancies are considered a pregnancy loss, where an ectopic pregnancy, whether that's considered a pregnancy loss, molar pregnancies, whether it's defined as a pregnancy loss or as a miscarriage. So it unfortunately it is a complex issue that still needs a lot of research into it. So I also wanted to share a couple of patient cases, just so you could have a sense of how this actually fits into the clinical practice. So so I wanted to start with patient case one. So this is a male and female couple. The female in this case is 30 years of age. She's been pregnant twice and unfortunately has had two miscarriages. These have been natural conceptions, right? So as you can already tell, this is a patient that is 30 years old, in which we wouldn't off the bat consider her to go through one, let alone two miscarriages. But that's the important thing of what we've discussed today, that not all patients, not even half of patients, are always going to have obvious risk factors, right? So trying to achieve pregnancy, she had gone through 4 rounds of IVF, totaling 5 single embryo transfers, 1 double embryo transfer. All of them had been negative, no biochemical pregnancies or anything like that. She had been tested for antiphospholipid syndrome, and it was negative. Her AMH was of 3.44, which is considered a normal ovarian reserve. In fact, it's considered in the perhaps upper end of the of normality. For people from the UK, you all use different units. So instead of nanograms, you would be using pmols. And this would be something like 21 people or something like that. She had excuse me. Let's see. The lights sense motion, so that may happen a few times. She had a normal karyotype. Her male partner was 36, otherwise healthy, normal karyotype. He did, however, have a low concentration, low motility, and high DNA fragmentation. They had done multiple treatments in Holland and in Germany. So when we analyzed this case, we proposed IVF with PGTA to make sure that the embryo that we were transferring was chromosomically normal. We normally would not recommend doing PGTA in this age group, but given the fact that she had 2 miscarriages, we thought that was appropriate. We also want to analyze her KIR-HLA. Sorry about that. And we also wanted to test her with an endometrial biopsy. So we found that she had a KIR that was AA, and her HLA was C1, C2, and his HLA were C2, C1. Now, KIR AA and the C2 part of the HLA is actually one of those combinations that doesn't go very well. So this was an important finding. During IVF, we got 12 eggs. We got 4 that fertilized, and we got 1 day 6 blastocyst. When we did the PGTA, luckily this embryo was euploid. Upon doing the biopsy, we found that her NK cells were increased, specifically her cytotoxic NK cells, and she did have a positive pathogen. So we gave her antibiotic treatment. We did a referral to our immunologist. The immunologist gave her medication along with the rest of the endometrial prep treatment. And luckily, with that only euploid embryo, we were able to achieve pregnancy and is now a healthy ongoing pregnancy. And the second and last patient case that I have for you today is a couple slightly older. She is 36. He is 36. She is otherwise healthy, but has never been pregnant, in spite of having tried for over 4 years. They had done 2 rounds of IVF. She had 1 single embryo transfer on day 3, but 5 single embryo transfers on day 5, and they had all been negative. This would actually be more of a recurrent implantation failure. But I do want to illustrate the immune factors that are involved. So we tested their karyotypes. They were both normal. Her AMH was at 0.6, which is a slightly lower AMH, and it is slightly lower for maybe her age group. Her TSH was on the kind of borderline, and she had negative antibodies. So when the TSH is above 2.5, we usually do treat to try and bring those TSH levels down. Her partner initially had azoospermia, meaning that he didn't have any sperm cells on the semen sample. We tested their KIR-HLAs, KIR-BA, C1, C2. He had a C1, C1, so there wasn't much to see with the KIR-HLA. We did IVF. We got 12 eggs. We did a testicular biopsy to get the sperm cells in order to fertilize the eggs. We got 2 blastocysts. One of them was euploid, and the other was aneuploid. They wanted to have at least 1 more embryo before moving on to the transfer, so we did a second round of IVF. We got 13 eggs. 4 blastocysts. This time, 3 were euploid. So we had a total of 4 euploid embryos. We did a thrombophilia panel, and she tested positive for a specific mutation that is related to an increase in blood clot formation. Her endometrial biopsy was okay, so we added low molecular weight heparin and low dose aspirin. And after the first embryo transfers, she achieved pregnancy and is now also a healthy ongoing pregnancy. So thanks to everyone for listening and bearing with the my lighting issues. And I would love to take a look at your questions and help in any way that I can.
Brilliant as always. Thank you so much indeed for explaining a tough topic as we discuss, and thank you for providing the cases, because I think many times those are the ones that we are really looking forward to see what can be done in particular case. So thanks a lot for that. And there are some questions in the chat, so thanks a lot everyone for adding those. And I guess we can go ahead with the questions. And again, if you have any more questions, you know what to do. You can go ahead and type those in the chat. But let's have a look at the questions that we did receive before we even started the event. As you can see here, we have a question from L. After 2 consecutive failed and unexplained frozen embryo transfers using IVF at excellent quality embryos, what would be the reason for this, and how do I increase chances of success with one good quality embryo left? I'm 34, everything is healthy and clinic sees no issues. Ate well, have done everything recommended, and should I take a couple of months break and try again? Any thoughts on that?
Okay, so again, this sounds more like, without knowing any of the rest of her background in terms of previous pregnancies or anything like that. You know, when we have 2 or more good quality blastocysts that haven't attached, we usually will classify that not as much as an RPL, but as a what we call RIF, or recurrent implantation failure. Now, here in your particular case, it's always important to remember that a good quality embryo, unfortunately, doesn't necessarily mean that chromosomically it would have the 46 chromosomes that we've been discussing. So great quality isn't always synonymous to euploid. And that's one of the things that we have to look at. But I do agree that for an embryo that isn't chromosomically normal, perhaps wouldn't be our first suspicion. So I think that perhaps after 2 transfers, of course it's okay to take a break, but I think that it is a good opportunity to start doing more in-depth studies into the embryo's environment, or into the environment that embryo is being placed into.
Okay. Thank you for your question, and thank you for helping out with that. I hope that was useful. Of course, if there are if you have any follow-ups, you know what to do. Let's have a look. Next question from Lou. What testing is useful for transfer patients generally with no prior losses, and what proportion of patients do immunological issues affect? Finally, does age have any implications?
Okay, so what testing is useful for transfer patients generally? So that is a great question, because actually, and this is coming back to one of the points that I was trying to make during the presentation. So we're actually not going to recommend most of these tests in patients that don't have either pregnancy losses or implantation failures. So other than maybe doing a mock cycle to see how your lining is growing with the medication or with the natural cycle, other than that, I don't think that additional or more in-depth testing would be warranted in your case. So that's something, it's important to know when to do these tests, but I think it's almost just as important to know when to not do any of these tests. The second part of your question was that what proportion of patients do have immune issues? Do immune issues affect? It's actually not the most common cause. So there are many other causes that should be investigated first. As I said in the beginning of the presentation, embryo or the embryo's genetics is actually the most common cause in RPL, and it is the leading cause for miscarriages at any age. So we always have to kind of see it as a list of priorities of what
Yeah.
one to rule out first. And finally, does age have any implications? That question on its own we can talk about that for an hour. There's a lot of ongoing research. It seems that immune conditions, autoimmune conditions tend to be more common in older patients, because of how the immune system works and how you're exposed to different antigens throughout your life, and then your body starts kind of making memory of that, so it becomes a little bit more reactive. Short answer, probably, but we haven't been able to establish a set cutoff point yet.
Okay. Thank you again for that. And I'm just looking, of course, there are some more questions. So let me go for the question from Emma, very short one. Any thoughts on IVIG for raised NK cells?
Can you repeat the question, please?
Sure. Thoughts on IVIG for raised NK cells?
Okay. So IVIG is one of the medications that might be used, not just in cases of raised NK cells, but also in different KIR-HLA combinations. So first of all, before I answer this, it's important to know that these types of medications should always go hand in hand with an immunologist's overview, right? They are the professionals that kind of have the ins and outs with these types of medications. So it's important that we always, have them in the loop when undergoing these types of tests and when deciding on what treatment is best. Now, as a treatment, IVIG can be used to regulate the immune system. The evidence is quite mixed, though, so it hasn't shown to really improve live birth rates. So each case has to be individualized because it's not just raised NK cells. There's not just one type of NK cells. There are different types of NK cells, and whether they're increased or decreased, that has to be evaluated. It's not the same thing as having an increased cytotoxic NK cell population is not the same as having an increased angiogenic NK cell population. So it has to be evaluated carefully.
Right. Okay. Thank you. That's important also to remember. Thank you a lot for that. Let's have a look. Danielle, there's a bit of a longer question. As you can see, I'm 35 with potential stage 3 or 4 endometriosis. No biopsy has been done to confirm, but I have a 8-centimeter cyst, endometrioma on my one ovary. My last cycle, I had 5-day, 5-6 blastocysts. All were tested through PGTA. 4 came back euploid. 1 was mosaic. I have transferred all 4 euploids. 2 failed implantation, 1 led to miscarriage at 8 weeks, and another resulted in a biochemical pregnancy. Do you have any thoughts on factors that may be at play or any treatment tests you can recommend in this case?
Yeah, definitely. I mean, endometriosis is not just a chronic condition that can cause pain during your periods, but it has a lot of other implications. So first of all, endometriosis is when the cells from the lining attach to other parts of the body, right? The most common site of those cells attaching is or are the ovaries. When these cells attach to the ovaries, that's what we usually will call a chocolate cyst. They tend to respond to the hormones the same way that the cells in your lining do, but they can attach virtually anywhere. And another place where they can attach, and I think it would be helpful to rule it out or to see how advanced it is something called adenomyosis. We sometimes think that it's a different category on its own, like fibroids or polyps, but it's actually endometriosis that has infiltrated into the walls of the uterus. So it is the same condition. And adenomyosis and endometriosis can affect the ovaries and the lining in different ways. In the ovaries, they can affect the amount of follicles and also the egg quality. While in the lining, they can have different implications. They can distort the cavity, so it can affect how the blood flow actually gets to the lining. It can also affect the way that your uterus contracts, making it extra sensitive, especially to hormonal stimulus. And lastly, it can create a pro-inflammatory environment. So I think that in your particular case, having those euploid embryos and those failed transfers, it seems like the issue may not lie within the embryo's genetics. So I think that in cases yours, it's especially important to really do some in-depth studying of that cavity and how the endometriosis or adenomyosis may be affecting that.
All right, thank you again. Very good to hear that there are some options that you can definitely look for and search. So thanks a lot for that. Let's have a look. Next question that I have here from Francisca. Does a lower immunological level, for instance, after heavy could without cold, without fever, matter for a soon coming transfer? May such situation improve the chances of implantation in case of a woman with Hashimoto?
Yeah, so with Hashimoto's, we have to remember that that's the more common cause of an underactive thyroid. So it has to be something that is closely monitored and tested for before doing the transfer, because we are going to want your TSH levels to be ideal. And those are usually controlled through levothyroxine. Now, I think that whether a cold may or may not affect a transfer, maybe there's no right or wrong answer there, but I think that most doctors or a large part are going to reason this as you having a cold probably means that your immune system is in some way dysregulated. Maybe it's upregulated, maybe it's downregulated, but it's probably not it's probably not going to be the ideal moment for a transfer. So postponing the transfer may be an option when going through a fever, with or without a fever.
Okay. Yeah. Very important. Again, thank you for that. Here's the next question from this. I cannot find a single clinic that knows what mast cell activation is and the negative consequences it will play, histamine overload in maintaining a pregnancy. Do you have any advice or thoughts?
So, like any immune condition, mast cell activation doesn't quite affect the cells that we'd be concerned with, which are the NK cells. They are different types of white cells that would be affected with mast cell activation. But the histamine overload can have an impact on uterine blood flow. So this is something that should be monitored. And when you mentioned that not a single clinic knows or has dealt with that, that's because most clinics are probably going to be run by gynecologists. So a clinic that has a reproductive immunology unit is probably going to be a place in which you'll be able to get that multidisciplinary treatment that you need. So that would be my recommendation.
Yeah, definitely. All right. Thank you. I do hope that was useful for you as well. Some more questions are coming in. Some of them are also from Instagram. So thanks a lot for that. And the question that we have here, how do you treat PCOS, BMI 19, and lupus anticoagulant for frozen embryo transfer? Any thoughts on that?
Hang on, let me just scroll to it because I
Sure.
did see
Sorry.
it just a second ago.
How do you treat PCOS? This is like the orange one. Okay.
Okay. So let's kind of break this question up in a few segments. So first of all, one of the more important elements here would be age to see how to think about PCOS, right? So PCOS with a BMI of 19, it's important that you include that information because a lot of people think that PCOS is in somewhat related to a higher BMI, but that is not, I wouldn't even say that that's even most cases. PCOS patients have very different phenotypes. In order for us to diagnose PCOS, you usually need 2 out of 3 conditions to be present. 1, irregular cycles. 2, hyperandrogenism, meaning male type hormones that could be elevated. And 3, a polycystic ovary upon the ultrasound scan. So that means that features like high BMI, obesity, insulin resistance are not even considered when diagnosing PCOS. So that's one stigma, let's call it that we should remove when thinking about PCOS. Now, PCOS unfortunately has been related to insulin resistance or the hyperandrogenism that I was talking about, and that can or may affect egg quality. So it's something that we need to keep in mind. We usually see higher levels of follicles or a high increased ovarian reserve. But it sometimes comes at an expense of maybe not the best egg quality. So that's something that we need to keep in mind. And an appropriate protocol based on your androgen profile should be used when determining whether we should use FSH, LH, or a combination of FSH and LH, or medications like metformin or inositol. Now, regarding the lupus anticoagulant, this comes back to the APS syndrome that we were talking about, the antibodies that can actually increase the clot formation. So there are 3 main antibodies: lupus anticoagulant, anticardiolipin, and beta-2 glycoprotein 1. Those antibodies, when increased, can be used to diagnose antiphospholipid syndrome. And when we diagnose antiphospholipid syndrome, we would recommend using blood thinners during both the preparation, pregnancy, and even after delivery. So blood thinners such as heparin and low-dose aspirin would be indicated in this case.
Mm-hmm. Okay, thank you for sharing. And actually, someone else asked in regards to the second case that you've shared during your presentation. So if you can clarify, I'm not sure I understand the protocol used for the first case. Sorry. You discussed the one with the KIR HLA-C incompatibility. Could you elaborate on that? Would heparin aspirin be sufficient?
And I think that's a great question, because the way that we treat KIR HLA is going to depend on the type of fertility treatment that we are undergoing. And that's part of the reason why I use this patient case in particular, because when we face recurrent miscarriage or recurrent implantation failure and we test KIR HLA, sometimes that is in the context of egg donation. So for example, if a woman had a KIR AA, we know that the ideal HLA is not going to be C2C2 or C1C2 for all that matters. So what we would do then is probably choose a donor with a C1C1 HLA, right? But in the patient case that that I presented, uh, it was an IVF cycle with own eggs and own partner. So we were, we had to deal with that particular HLA. So we made a referral to our reproductive immunology unit. Our immunologist recommended a treatment with something called GCSF, or granular colony stimulating factor. And that was the treatment that was used in that case for the KIR HLA. I'm not going to say incompatibility, but the KIR HLA combination.
All right. Again, thank you. I do believe that was useful again. So thanks for the clarification. And now we will have a look at Jenny's question from Instagram. 42 with 2 miscarriages, killer pregnancy cells are an issue, and recommendations. I have 1 embryo waiting testing, 2 rounds of IVF. First round 3 eggs, got 1 embryo. Second round 8 eggs, no embryos.
Can you repeat the part about the NK cells, or the because you said cells, right?
It's like 42 with 2 miscarriages and killer, so NK cells, right, are an issue. And any recommendations? Yeah, this is just the information we have.
Yeah, so it would be very interesting to see how the NK cells were diagnosed, because the more common tests for testing the NK cells is by something called the immunohistochemistry, or IHQ, in which we test specific markers, CD56, CD138. Now, the most current research has shown that these markers, and this is part of the reason why testing for NK cells can be quite complicated sometimes, because the amount of NK cells within the lining, which is already the first difference. I don't know if the NK cells that you're talking about were through a blood test, or whether they were tested in the lining but through a marker test. So that would be the first distinction that we would need to do. What we have seen is that the blood NK cells and the NK cells tested from the markers don't always show the real representation of the number and type of NK cells present. And also, in order for us to test for the NK cells in the lining, it has to be at the time in which implantation would occur. So roughly after 5 days of progesterone. So whether you test at the start of the cycle, middle of the cycle, or end of the cycle, the NK cells are going to vary. So first of all, we would need to know a little bit more about the NK cells in order to determine how to approach that case.
Of course, you definitely need more information, but thanks a lot. And of course, if you'd like to get some more details, you can get in touch with us directly or with Dr. Zavala, and I'm sure the team at Clínica Tambre would be happy to help you out with some more details as well. And I believe that will be our final question, but if you have any more, you know what to do, you can still type those in. And I believe you can see it, Dr. Zavala, there are like 3 parts of it. So I transferred a euploid embryo in December, achieved pregnancy, but there was a miscarriage at 6 weeks, was taking Clexane and aspirin, but no known blood clotting issue. Presume this was prescribed as precaution. What else could have happened in your opinion? And all other tests were okay. Had karyotype, KIR, HLA test, also had endometrial biopsy done.
Yeah. First of all, I'm very sorry with what you went through. As I said, having a miscarriage is always a very challenging experience. Having a euploid embryo transferred and still having a miscarriage, as I said, while the genetic contents of the embryo might be the leading cause for a miscarriage, it doesn't necessarily mean that that's the only cause. So there can be other factors that are at play. Also, using Clexane and aspirin are specific for certain certain issues that we may have, but it's not like it's not something that can help us in any condition. So having one miscarriage in these conditions wouldn't necessarily warrant some of the more specific tests that we've discussed today. But I think that um, analyzing the cavity, searching for polyps, for fibroids, for anything a little bit more in depth would probably be a good idea before moving on to another transfer.
All right. Again, thank you so much for that. And Dr. Zavala, just give me a second. There is one more question that we've received. So just give me a second. I need to. It was in. We did receive it on Instagram. Sorry. So just give me a second, and I should be able to see that. Okay. Sorry, I will read it for you. I cannot copy that for some reason, but that's okay. So I had 3 failed IVFs, 2 didn't make it to blastocyst, and the other one simply didn't have follicles, not enough dose of FSH. I have had 2 miscarriages from spontaneous pregnancies, one being mid-trimester at 18 weeks and 5 days. Is it possible that one's body is not agreeing with IVF, as I never got pregnant with any despite having a lot of follicles? Is there any such thing? The reason for IVF with ICSI in the first place is male factor. Ovaries are polycystic in nature, but not diagnosed as PCOS, and the patient is 37. This is the information I got.
Yeah, can you read it once more? It was a bit long, so I just want to make sure that.
Yep. 3 IVF failed, 2 didn't make it to blastocyst, and the other one simply didn't have follicles, not enough dose of FSH. I have had 2 miscarriages from spontaneous pregnancies, one being mid-trimester at 18 weeks and 5 days. Is it possible that one's body is not agreeing with IVF, as I never got pregnant with any, despite having a lot of follicles? Yeah, and the reason for IVF with ICSI is male factor.
Yeah.
37.
Okay, so a few factors to consider there, right? Mm-hmm. So we know that egg quality can be both affected within that age group, and we also know that PCOS can also have an implication on this egg quality. So I think that it would be important to look at the stimulation protocol that was made, and also to see what conditions you were going into that those stimulation rounds as. We have to remember that PCOS is the most common endocrine condition in women. So this means that the hormone levels might be affected, and these should be closely looked into. Now, what you're describing is something that we have seen before in cases in which it seems like you're getting quote unquote better results from even a natural conception than from IVF. So the reason why that may happen is because naturally you're going through many follicular or many egg selections basically each month by just having a regular pattern of ovulation. Well, in IVF, you're doing that one cycle. Now, if there are multiple follicles and these are not responding to the medication as we would expect them to, it seems like what is happening here, without knowing the amount of eggs that were collected in each of the cycle in each of the cycles that didn't make it to blastocyst, it seems like there's something called a poor ovarian response, meaning that the follicles are there, but the ovaries are not responding. So I think that giving that stimulation protocol a second look would be the first place where we should begin.
Yeah. Okay. Thank you once again for your question. I do hope it was useful for you as well. And I guess we will be finishing. There's one more question I still think we can answer, but the final one, okay? My clinic had used a combination of prednisolone and dexamethasone. Would love your thoughts on this.
Yeah, that's a treatment scheme that is sometimes used by immunologists. Most of the time, you are required to be on prednisone prior to the embryo transfer, and then switch to a different type of steroid, which is the dexamethasone, and sometimes switching back to prednisone after a certain time. Um, uh, Depending on the reason why this was chosen. But yeah, this is one of the treatment options that we would have in certain cases, such as an increased amount of NK cells.
All right. Crystal clear. Thank you so much again for your question. And well, we will be finishing for today. So thanks a lot, everyone, for sending the questions, for staying with us this evening. And Dr. Zavala, as always, it's been great to have you. I do believe it was really helpful. Anything else you wish to add before we end for today?
I would just like to emphasize that we have covered a lot of testing today, a lot of conditions, but we always need to be cautious with the tests or the treatments that we seek with these types of conditions. So always follow the guidelines in your clinic or from your doctor.
Definitely. Thank you so much indeed. And of course, well, we hope this discussion has provided some helpful information. I do believe so. And just to remind everyone, as Dr. Zavala already mentioned at the beginning, he will be in Dublin, in Ireland, on the 21st and the 22nd of March. The European Fertility Society will be there as well. So if you are anywhere around, it's a great opportunity to meet Dr. Zavala and actually the team at the of the IFES as well. So thanks a lot, everyone, once again. And of course, if you'd like to learn more, we are coming back with some more events, new topics. There are plenty of those. And if you found this interesting and you would like to be notified about some more upcoming events, stay tuned, follow us on YouTube. All the videos will be available there, including this one. And well, for any upcoming events, you can simply go to myivfenses.com. Dr. Zavala, a great pleasure to have you. I'm really looking forward for some more events. I know there are more coming up. So thanks a lot and
Thank
take
you.
care.